Great to have you here. So, gallbladder problems are so common. Maybe you can start off our viewers by telling us, what is the gallbladder? What does it really do?
Well, the gallbladder is an organ that's located in the right upper part of your abdomen, just underneath your liver and underneath your ribs. And it functions as a reservoir to hold bile that your liver makes, which ultimately is used to help you digest fats when you eat.
So it really does have a real purpose.
Sure does. It sure does. And when you eat a fatty meal or anything that contains fat, your gallbladder will contract and it will squeeze all the bile down the bile duct into the intestines, and that's where it will help digest those fats.
So that's important for digesting food, as you say, but sometimes things go wrong with the gallbladder. Maybe you can tell us a little bit about that.
Sure. Well, as I mentioned, it is a reservoir to hold bile, and sometimes stones can be formed within the gallbladder. And when stones are formed, if they get stuck right at the opening of the bile duct, they can cause pain. And if they cause pain for a prolonged period of time, they can lead to infection, and that's when we have to deal with this on an urgent basis. And
people get into trouble. But maybe we can take even a step back. So it sounds so interesting, right? Stones in the gallbladder. What's a gallstone?
Well, a gallstone is a stone that's comprised of a few key ingredients, mainly cholesterol and bile salts. And when the body creates these chemicals, and they tend to either stay in the gallbladder for prolonged periods of time, they can actually create crystals and form these stones.
And we actually have a picture on the screen for our viewers of these are actual gallstones.
Yes, they are. And if you look on the bottom of the screen, the ruler is in centimeters. So these stones, these are typical cholesterol stones. They're they're yellow in color and they're irregularly shaped. And they're about anywhere from a half a centimeter to a centimeter in size.
And they really are hard, like a stone, if you were to hold them, or
they're hard depending on how long they've been in your gallbladder. If they're early or new formed stones, they can be somewhat soft, which definitely helps to remove if we have to do it by an endoscopy.
And so, tell us a little bit more about why, in some people, does the cholesterol and the bile salts, why do they combine and form these stones in the first place?
Well, they combine when there's differences in concentrations of these, of whether it be too much cholesterol or too much bile salts. Sometimes the patient's gallbladder doesn't contract that well, and sort of the bile just sits there. It's what we call bile stasis, and that's a real predisposition for forming these stones and crystallization. Once the crystals are formed, then it's like a wildfire, and they just continue to grow and grow and grow.
And tell us a little bit about what happens when a gallbladder has stones in it.
Well, when a gallbladder has stones in it, for the vast majority of patients, they don't feel or complain of any symptoms at all. Sometimes when the stones, as mentioned before, if the stones get stuck or get blocked within the bile duct in and of itself, they can cause pain. It's much like if the gallbladder is trying to contract and there's something blocking the opening of the bile duct, you're going to feel pain. So that's the typical or classic symptom that patients feel.
Tell us again, are there particular people who are at more risk to get gallstones and gallbladder problems?
That's a great question. Patients are people that are overweight, female gender, especially between the ages of 20 and say 50 during their years of fertility, are at increased risk, and mainly that has to do with hormones, especially estrogen. Women on birth control are at slightly increased risk. People with certain diseases, diabetes, sickle cell disease, people that have rapid weight loss from recent gastric bypass surgery, or chronic illness in the hospital requiring chronic intravenous sedation. These are patients that definitely have an increased risk, as well as age. As you get older, we are more prone to developing these stones.
And it's really interesting, right, because you mentioned people who are very overweight have a higher risk, but also people who lose weight pretty rapidly have a higher risk.
Yeah, that is interesting.
What is it about the weight loss? Do people know what happens?
For some reason, the bile within one's body tends to be what we call more lithogenic or stone forming when they're having rapid weight loss. and that leads to stone formation.
And so kind of one classic kind of patient we sometimes see is the woman who had a baby, maybe several months ago, 10 years ago, lost a lot of her baby weight, has had this rapid weight loss, is in that age range, has had a lot of hormonal shifts, and comes in with the kind of pain that you described.
Yes, Andrea, that is the kind of classic patient that we see, but not always everyone reads the textbooks per se, and sometimes we do have interesting cases that don't always present in that classic manner.
That's absolutely true, and in fact, it's especially with older patients. I think you and I in the hospital have both seen people come in where the concern is this patient having a heart attack? Because the pain is not always in the classic textbook place. It can be actually very severe pain with gallbladder disease or gallstones, and people come in maybe with some kind of pain more towards the center and are worried because of the patient's age that maybe there's something going on with the heart, and as everything settles down we realize no, it's probably not the heart, it's probably the gallbladder.
That's true. I mean, typically, or the classic symptoms are pain that you feel in the right upper quadrant or right upper abdomen, usually associated with eating. So within 30 minutes after a meal you might experience this pain. It could be sharp, it could be crampy, it might radiate to the back or even up to the right shoulder. Sometimes people just have nausea and no pain after they eat. Sometimes people do get pain that radiates into the chest. So you're right, especially in an elderly patient that's having these symptoms. Yes, we have to think about gallbladder disease, but it's very important that we make sure it's not their heart.
Absolutely, that's absolutely true. And so tell us a little bit more about, so when the gallbladder is contracting and there's a stone stuck and people are getting pain, what's the typical kind of course then? Does this last over hours? Does it get much worse?
It's a great question. The typical symptoms that we get in the pain in the right upper quadrant, again, it starts 30 minutes after, usually 30 minutes after meal. It can last for seconds or minutes. It can come and go, mainly with eating. Sometimes it doesn't always occur with eating, but when it starts to last for more than a few hours, especially 4 hours, and it's constant pain, or it's associated with fever, nausea, vomiting, you start seeing that your eyes are turning yellow. Then we're dealing with a more serious condition when gallbladder or gallstones have caused blockage long enough where there's an infection probably setting in within the gallbladder, and then we need to deal with it on an urgent or emergent basis.
And I think that's really an important point, and we're going to be talking about some of the treatments when we come back in the next segment, but maybe you can mention it's not just about pain, but there really are other complications that we need to kind of worry about when people have acute gallbladder problems.
Right. So one of the things is that you need to make sure that this is not an acute infection of your gallbladder, which is what we call cholecystitis. Acute infections in the gallbladder usually are treated surgically. Sometimes antibiotics can kind of quiet or cool off the infection within the gallbladder, but ultimately it usually requires surgery to remove. The next potential complication from gallstones is that sometimes gallstones can actually, small enough stones or even grumous, small sandy-like stones can leave the bile duct or leave the gallbladder, travel down the bile duct, and get stuck at the lower end of the bile duct right before it drains into your intestines. And that area is a little precarious in the sense that your pancreas is also located in the same area, and its duct that drains pancreatic juices also shares the same area where the bile drains, and that can actually lead to irritation of the pancreas, which is what we call pancreatitis.
So you can get a blockage of that duct and then actually inflammation that goes to the pancreas.
That's correct. And pancreatitis, most people when they hear about inflammation of the pancreas or pancreatitis, they think it's usually associated with drinking. But more commonly in the United States, pancreatitis is becoming a problem associated with gallstones, especially as we have a rising rate in obesity in our society.
And pancreatitis really is something to take very seriously. It's not lightly.
It sure is. It can be a life-threatening situation.
So there really are reasons to think about treating gallstones and gallbladder disease.
Yes, there definitely is.
And when we come back to our next segment, we'll talk a little bit about what you do as a gastroenterologist to help people with gallstones and when people need to really go see a surgeon to get that gallbladder out.
Absolutely.
Great. We'll be right back after this short break. Stay tuned.
It's one of the many ways to fight osteoarthritis pain. For more information on managing pain, go to fightarthritispain.org.
Oh, those boys are much too much. Those boys are much too much. We got the spirit. We're hot. We can't be stopped. We got the spirit. We're hot. We can't be stopped. We're going to beat them and bust them. Beat them.
The smallest moments can have the biggest impact on a child's life.
Let's get a little bit rowdy. R-O-W-D-Y.
Take time to be a
One
dad
more time.
today.
Oh, those boys are much too much. Those boys.
2 out of 3 people with diabetes die of heart attack or stroke. That was his wake-up call. This is yours. Ask your healthcare provider how you can lower the risk. To learn more, go to diabetesactnow.org.
The first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
We're back with Dr. Brian Schwender, a gastroenterologist with the Norwalk Medical Group. Welcome back, Brian.
Thanks, Andrea.
So we were talking in the last segment about gallstones and gallbladder problems, and there really are times when we have to address the gallbladder and the gallstones and think about ways to get those things out of somebody's body. Tell us, what do you do as a gastroenterologist to help people?
Sure. Well, we always try to assess the level of acuity, meaning the criticalness of the problem in front of you. So if the patient comes to you and is telling you that they're having these classic symptoms of pain in their right abdomen after they eat and they have identified gallstones, we do recommend that they have their gallbladder removed, because you never know when that will lead to a chronic or severe acute infection in the gallbladder.
Maybe we can just stop for just a second, just take a step back. And how do you identify gallstones in the gallbladder? What's the best way?
Sure. So the best way to identify gallstones is by doing an ultrasound, which is using sound waves essentially to look very, non-invasively.
Non-invasive, no radiation.
That's
for that.
correct. That's correct. And it's a great way of identifying gallstones and basically telling people if they're at risk of having bad complications from gallstones.
And actually, when people are having acute symptoms from it, they actually can do the ultrasound and see if there's inflammation around the gallbladder too. They can kind of use the ultrasound to press on the area of the gallbladder and see if it really hurts.
Yes.
To kind of give an indication, yep, this really is the gallbladder causing your symptoms. It can be really pretty useful.
It sure can. And once we have that bit of information and we have the classic presentation or picture with the patient in mind, that's when we usually recommend surgery. Obviously, surgery is best in patients that are good candidates for surgery. So we have to assess the patient's surgical risks, make sure that it's safe enough. I mean, any surgery is somewhat risky, but we need to make sure that any kind of risks that they do have for surgery are modified before surgery, and then they're recommended to undergo this procedure.
It is good to know that for many people, gallbladder surgery or cholecystectomy is kind of not your mother's or grandmother's cholecystectomy anymore, right?
That's correct. I mean, I'm not a surgeon, so I don't do the procedure. But these days, the standard of care is to remove the gallbladder surgically by laparoscopic means, which is nothing more than a surgeon making 3 small incisions within the abdomen and doing everything with little mini cameras and mini instruments within the abdomen. And the recovery time is quite quick. Many times these procedures are done same day, so they can leave the hospital within the same day of their surgery. And the procedure itself might take under an hour.
It's really a nice advance. My husband, when he had his gallbladder out, came out with 3 little scars. His mother, who had her gallbladder out, has a kind of a much bigger scar from surgery years ago. So it's a lot easier. Now, not everybody can get their gallbladder out laparoscopically. That's kind of depends on what's going on with the patient, but a lot of people can. So.
Sure. I mean, when it comes to the selection of whether you can have it done laparoscopically or not, usually folks, when they undergo this procedure, it's started out by laparoscopic means, and if for whatever reason in the operation they see that the gallbladder is very sick, or they have to convert it to an open procedure, which is kind of like what your grandmother had back in the day, then they would do it right then and there. So.
Tell us, though, you do a specialized procedure to look at gallbladders and take a look at gallstones and help patients with these problems.
That's correct. So the procedure that I do it's a specialized endoscopic procedure called ERCP. And this procedure is a procedure which we can actually access one's bile duct through an endoscopy, through their intestines, without having to make any incisions in the abdomen, and try to fish stones out that have been either stuck in the bile duct or left behind after one's surgery to remove their gallbladder.
And it's worth saying it's just easier to call it ERCP because the regular word for it is about a mile long.
That's correct. That's a long.
It's a long way. ERCP is much easier. We'll stick with that.
That's fine.
So it is an invasive procedure, but it doesn't require any external cutting to get to the area.
That's correct. It does not require us to make any outside incisions, but many times when we do this procedure, we do have to make small incisions right at the opening of the bile duct. It's a little muscle down at the lower end. It's a sphincter muscle, much like the sphincter muscle in the anus. And we have to make that opening wider to really allow for us to pull these stones out.
Maybe you can walk us through a little bit what happens with an ERCP.
Sure. So first off, just to lay any rest or uneasiness of people viewing today, we do this procedure under sedation.
Absolutely.
So patients are very comfortable. They're usually lying on their stomach in the radiology suite, where we need the assistance of special x-rays, and I'll explain that in a moment. So while one's asleep, we put a small, thin, flexible tube that has a camera and a light at the end of it, down through the mouth, down into the food pipe or the esophagus, into the stomach, and then into the beginning of the first portion of the small intestine, where the bile drains.
And that's a lot like people may have had upper endoscopies for other reasons. That part of it is pretty similar to those.
That's correct. It's pretty much the same procedure. I just use a special scope. And then once I get into that portion where I can see where the bile drains, with a series of small wires and tubes, I'm able to gain access within the bile duct from the intestines with the help of a special x-ray machine.
And when you're doing that, you're actually seeing in real time where you're going with your camera.
That's correct. And once we are able to access the bile duct, which is probably the toughest part of the whole procedure, we're then able to inject special contrast into the bile duct to visualize almost like a road map of one's bile duct and look for things like stones or debris or anything that could be causing the patient's symptoms.
Mm-hmm. What do you do based on what you see?
So if we see stones, then we know that we're doing a therapy, meaning we're going to need to remove these stones. So at that point, I make a small incision at that muscle to open up the muscle to then allow me to either with a basket or a balloon pull that stone or stones out of the bile duct to free the bile duct of these stones.
So sometimes it's just a matter of size, that the stone is too big and it can't come out that area, and if you open it up a little bit and kind of help the stones out, they can be released.
That's correct. Small stones can actually pass on their own. usually anywhere from 1 to 2 millimeters in size. Sometimes they don't pass, and when they don't pass, they can typically give you the same types of pains that you had after your gallbladder was removed. It's not to say that the surgeons didn't do their job, but some people actually have small little stones that are left behind that didn't give them trouble in their bile duct until they grew a little bigger and then caused a blockage and pain.
Yeah, so you're saying you can have had stones and had your gallbladder out and be feeling great, and then at some point later have similar symptoms, and it turns out, dang, there's still a stone there.
Yes, and that's the biggest frustration with most patients when they come in. They thought that they took care of this a year or two ago, and now they're having recurrent symptoms, or they come in with a bad infection in the bile duct, because stones that are stuck in the bile duct can lead to a pretty serious infection called cholangitis.
And so that's really, since the gallbladder is already out, can't do that again. That's where
correct.
you come in to do this ERCP and try to get any remaining stones out and clear all those ducts.
That's correct. I mean, this is in today's day, this is standard of care to remove any stones that have been left behind, or stones that are in the bile duct. Back in many years ago, before ERCP was out and ready for prime time, surgeons would have to actually go in and explore one's bile duct in an open surgical manner, which was a pretty high-risk surgical procedure and very involved. So this is a much better way to approach this problem.
Maybe you can mention briefly about MRI equivalents of ERCP, because now we have imaging that can give
Right.
us some diagnostic help, like the ERCP, although can't do the therapeutics that you do.
That's correct. Well, MRI is a great advancement in terms of helping gastroenterologists that do ERCP in identifying problems within the bile duct in a non-invasive manner. ERCP is an endoscopy. It's invasive. It has complication risks. One of the big ones is inflammation of the pancreas, much like the gallstones that caused irritation of the pancreas. Well, since we're working in the same area where the pancreas is, we can cause bad inflammation of the pancreas.
So you like to have the diagnostic test that's non-invasive, and then if you need to, you can go in and do the invasive procedure.
That's correct. That's correct.
One question I want to make sure I ask, we have about less than a minute left, is people often wonder, if the gallbladder really had a function, are people really okay without it when they come out?
Sure. No, that's an excellent question. I get that question all the time. And what I tell patients is that, yes, you can live without a gallbladder. It's not critical. I mean, it does, as I mentioned, its function to hold and store bile. But that doesn't mean that if it's out, you'll still be digesting fats. Bile will still be made by your liver. Sometimes people after surgery will experience some diarrhea, and that's because bile, when it continues to flow into the intestines, it can actually cause irritation within the colon. But many times when people do get this post removal of gallbladder diarrhea, it tends to go away within a few weeks to months.
And sometimes the risk of leaving a sick gallbladder in, certainly that outweighs the risks of these post-operative complications often, and the stones too often really need to come out.
Sure, that's correct.
So if people feel like they're having symptoms, they should definitely go see their doctor and get evaluated.
Exactly.
Brian, thank you so much for being on our show. We've learned so much about the gallbladder and gallstones. We really appreciate your expertise.
Thank you so much for having me on your show.
When we come back, we'll answer this week's health question. But right now, let's take a look at some of the upcoming events sponsored by Norwalk Hospital.
Folks, why won't we go to the doctor? My uncle called, speech all slurred, complaining his arms numb. He called everyone. He even called my daughter Tiara, because, you know, she's got a year of nursing. Everyone thinks he needs to go to the doctor, including me. So he said, well, will you take me? I'm like, I'm on the road. He goes, I'll wait. Stroke's no joke. If you or someone you love have symptoms of stroke, don't wait. It may be too late. Dial 911. Time loss is brain loss.
The first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
The smallest moments can have the biggest impact on a child's life. Take time to be a dad today.